Great. Good evening, everyone, and welcome to AF New England's Spring Speaker Series webinar, Demystifying and Delabeling Drug Allergies. My name is Jan Hansen, and I'm president of the Asthma and Allergy Foundation of America, New England chapter. And we're just delighted that you've all joined us tonight for this special webinar. Our expert speaker is Ashley McLennan. Ashley is a board certified pediatric nurse practitioner with a clinical focus in allergy and asthma and immunology. She received her bachelor's degree from Boston University and her master's degree in nursing from the MGH Institute for Health Professionals. In her clinical role at Boston Children's Hospital with the allergy and asthma program there, she manages a wide range of allergic disorders in children. And in addition, Ashley enjoys educating patients and healthcare providers in understanding best practices in allergy management. Ashley's here tonight with us to help us understand what is a drug allergy, to learn more about the misdiagnosis and overdiagnosis of penicillin allergy, to understand why an unverified penicillin allergy may be a problem, how various adverse drug reactions are classified, and what is the process for delabeling a drug allergy. We're excited to have you here tonight with us, Ashley, presenting on this topic. And I'll be introducing Ashley to you officially in just a few moments. But first, for those of you who are not familiar with AF New England, we're a patient education and advocacy nonprofit. Our mission is to improve the quality of life for all people who have or are impacted by these allergic diseases. We serve all 6 New England states, and we've been doing this since 1979. We fulfill our mission through a wide range of activities, including our awareness initiatives, our legislative advocacy for improved public policies for our community, through our support for research, and that includes our $10,000 Medical Fellows Research Grant, through our support services for you, our community, and through our educational programming, such as our speaker series webinars that we're having tonight. Now, tonight's webinar will be recorded and will be available for future viewing. So if you want to see it again, to remind yourself of what we discussed tonight, or if you want to refer to somebody else who was not able to make this program, you can go to our website, asthmaandallergies.org, and it's saved for you for future viewing on our YouTube station. I do have some brief program notes to share before we get started. We ask that all attendees remain on mute so that everyone has the best possible audio experience, please. Thank you. If you have a question at any time, please type it into the chat. We're going to reserve time at the end of the program for us to get to those questions for you. Any mention of a company or an institution or an organization or its products or services should not be viewed as an endorsement or a recommendation by AFA New England. And of course, information that's presented here tonight in the webinar should not be used by you as a substitute for professional medical care to diagnose or treat any specific illness or symptom that you're having. And now, I am very, very pleased to introduce Ashley McLennan to you tonight, who's going to take us through some very important information. Ashley, I'm turning this over to you.
Wonderful. Thank you. And thank you so much for the invitation to be here with you guys. I am going to share my screen. Let me know if this is viewable now. It is. Wonderful. Okay, great. So first of all, a thank you to Jan and to AFA New England for the invitation to be here with you guys this evening. As we get started, I just want to invite folks, if they are comfortable doing so, to just use the chat to introduce yourself quickly, and to the extent that you feel comfortable sharing, perhaps say a word or two about what interests you about tonight's topic. Perhaps you have personal experience with a medication allergy, or you are a clinician who has questions about this topic. But I invite you, as you will, and as we get started, to just take a second and add to the chat so I can do my best to speak to you specifically in those interest areas tonight. So to get started, let's dive in. I want to start by saying I have no disclosures relevant to the topic this evening, but want to take just a minute to sort of say a word or two about what got me into this line of work. As Jen shared, I'm a pediatric nurse practitioner in the Department of Allergy at Boston Children's Hospital. I see patients for a whole range of allergic conditions, and I am also part of efforts within the department to improve the way that we provide care for patients referred to us for a evaluation of antibiotic allergies. The efforts that we have undertaken at Children's are far from unique. I want to acknowledge at the outset that I stand on the shoulders of folks who have made a career out of this work, who are the ones doing the research and getting the data to better support these approaches to care. So here at Children's, Doctors Linda Schneider and Brittany Estey and Andy McGinnity have long championed the quality improvement work that we are doing across town at MGH. Doctors Blumenthal and Mariana Castells are folks whom I will speak to and quote and reference and borrow slides from. Their names are going to appear throughout this work. I'd venture to guess that there's probably not a single original thought in what I'm sharing tonight, but want to at least begin by laying out what I hope to cover this evening. So as Jen shared, brief learning objectives for tonight will be to discuss what is a drug allergy and how various adverse drug reactions are classified. To get into some more details and nuance about both the prevalence but the consequence of unverified penicillin allergy labels. And then spend some time at the end to discuss what allergy delabeling might actually involve. I hope that's more or less what folks were expecting from the evening. And I anticipate that at the end, we'll have plenty of time for questions. I was also reminded to pause periodically for questions along the way and in between each of these sections. So I'll try to also take some questions as we go. But for this evening, let's dive in. So I think it's helpful to begin with a shared definition of what is a drug allergy. And because drug allergies are actually one particular type of adverse drug reaction, I think it's actually, and because those terms are sometimes used interchangeably, I think it's actually really helpful to start with that larger definition or larger category of an adverse drug reaction. So, what is an adverse drug reaction? So, by definition, an adverse drug reaction refers to any unwanted or harmful reaction to a medication. And there are two really distinct types of adverse drug reactions. Type A reactions are going to make up the vast majority of reactions to a medication. And these include the predictable side effects of a medication, the ways in which the medication interacts with other medications you may be taking or foods taken in conjunction with a medication, for example. And then there are type B reactions, which actually make up a really small minority of reactions. And these include allergic reactions, pseudo allergic reactions, and some of the just like idiosyncratic responses to a medication. So let me say a word more about both types, but start with the type A predictable reactions, since far and away those are the most common to occur. So type A reactions have sort of these central characteristics. The first is that these types of reactions can affect anyone, not just individuals who are perhaps at increased or more susceptible risk for those reactions. Type A reactions are also dose dependent, so they are more likely to occur and more likely to be severe at higher doses of the medication. They're largely based on how the medication works in the body. So, some common examples of type A reactions are going to be that jittery sensation you get when using albuterol, which is just a known effect of the medication working in the body. Another example of this, very common and relevant for tonight's topic, is experiencing diarrhea while you're taking an antibiotic, right? So diarrhea caused by antibiotics is actually a secondary or indirect effect of the way that the antibiotic affects both the targeted bacteria, but also the gut bacteria. And so diarrhea is a known common side effect of a medication. Um, Other more severe or idiosyncratic reactions, right, could be things like kidney failure or hearing loss with overdoses of certain aminoglycosides like gentamicin or tobramycin, or bleeding risks or hemorrhage, right, caused by an interaction between two medications like warfarin or Bactrim. So these are all potentially severe outcomes of using a medication, but these are predictable to a large extent. By contrast, type B reactions are the unexpected reactions to a medication, and they also kind of come in three different varieties. The first are just your simple intolerances, right? These are side effects at a subtherapeutic dose of the medication. An example is some patients will experience like ringing in their ears after a single dose of aspirin. Not specifically an allergic reaction, not an immune response, and yet unexpected side effect of a medication. There are also what are called idiosyncratic reactions to a medication. And this is something where it's not going to occur in most patients treated with a medication. And it doesn't have to do with the way this medication works in the immune system, but is rather this rare reaction caused by an individual's response to a medication that doesn't occur otherwise. So it's something about the way that the pharmacogenics of this medication affect an individual. And then, and really what brings us here tonight, are the immune mediated reactions or your allergies to a medication. So allergic reactions are typically the byproduct of your immune system's response to the medication. Allergic reactions to a medication typically occur when the body recognizes the medication or a metabolite of the medication as a danger or a threat and tries to attack it. And so the process of attacking the medication causes the body to release various chemical mediators, which result in the symptoms that we experience as allergy. True drug allergy reactions range in severity from mild to life-threatening. They can occur either immediately, so within minutes of taking a dose of the medication, or they can be more delayed, occurring days into a course of the antibiotic, or even in some cases, days after completing a course of the medication. Allergic reactions. So again, we're talking about a subset of adverse drug reactions, are then even further categorized and subdivided according to the mechanism underlying the reaction. And so one language that we'll use later is the difference between an IgE or an antibody mediated reaction versus a T cell mediated reaction. And there are further flavors therein, but we risk getting lost in the weeds when we go too deep here. So I'll just say allergic reactions also come in a variety of flavors. While all medications have the potential to cause these adverse drug reactions, far and away the most commonly reported drug allergy is to penicillin. Penicillin, and I think worth pausing and spending a moment introducing her now, is an antibiotic, right? It's a medication that's used to treat bacterial infections. And given that penicillin is safe and effective against so many common infections, it's also the most commonly prescribed antibiotic. It accounts for over 20% of all outpatient antibiotics prescribed in recent years. Penicillin in particular belongs to a class of antibiotics called beta-lactam antibiotics, which are named for their molecular structure that we see here. Other beta-lactam antibiotics, such as cephalosporins, ampicillins, monobactams, look similar, and they share this central ring, which is shaded right here in pink. Beta-lactam antibiotics as a class are widely used to treat a large number of various bacterial infections. And penicillin specifically is the go-to antibiotic choice for treating many common infections, such as strep throat, ear infections, sinus infections, pneumonia, skin and soft tissue infections, dental infections, and even some sexually transmitted infections like syphilis. Um, Penicillin is a great example of a narrow spectrum antibiotic, meaning it targets just a few particular bacteria compared to broad spectrum antibiotics, which target a wide range of bacteria, including what we often refer to as like good bacteria in the body. And this narrow spectrum means that compared to other antibiotic options, penicillin is associated with fewer side effects. And yet there are some, right? So the most common type A side effect is going to be GI upset and diarrhea, as well as some delayed but otherwise benign rashes. Penicillin can also cause type B reactions, right? And the reactions that are mediated by antibodies to penicillin will cause immediate onset of symptoms such as hives, and immediate meaning like typically within an hour of a dose of the medication, hives, angioedema, which is like swelling of the lips, tongue, throat, or oral mucosa, shortness of breath, even something like anaphylaxis. So this is an IgE mediated reaction, or a reaction mediated by antibodies to the antibiotic. But there are other types of non-IgE reactions to amoxicillin that can also be life-threatening. So these are the kind of other flavors of antibiotic, which include some type 2 or like cytotoxic reactions, such as hemolytic anemia or petechiae, type 3 reactions, which are actually a reaction caused by this immune complex. The classic example of which is something like serum sickness reaction, which is associated with a rash, but also fevers and joint swelling. And it can also cause some type 4 or T cell mediated reactions, which include symptoms of severe blistering rashes, necrosis of the skin tissue, swollen lymph nodes, oral lesions or sores on the inside of the mouth and the mucosal membranes. I realize as I'm running through this list, but if I got a little faster running through this list of reactions, I could probably have a neat side gig as like a voice actor for the final 10 seconds of a drug allergy commercial, right? Like notify your doctor right away if you experience symptoms such as headache, change in vision, difficulty breathing, suddenly sprouted tail, right? Or so on. But the reality is all medications carry the risk for potential adverse drug reactions. And so when they're prescribed, it's typically because the potential benefits are felt to outweigh those potential risks. So now we've introduced penicillin. We've talked about all the ways that it can go wrong. Let me pause real quickly here and just see if there are any immediate questions that I can help clarify before we move on to the next section. Nothing immediately. That's okay. I'm going to try to keep an eye on the chat too. Thank you, Jen, for doing so. We'll keep moving on. Feel free to throw questions in as we go, and we'll loop back to this again at the end. All right, so we've just covered how penicillin is the most commonly prescribed antibiotic in an outpatient setting, how it's also the most commonly reported drug allergy. And it looks like some of you in the chat indicated personal experience with drug allergies. So it may now be understandably questioning whether what you or your child experienced was in fact an allergic reaction and why it matters. So let's dive into that. Are you actually allergic? In the US, the prevalence of a reported or documented penicillin allergy is somewhere between 9 and 12% of adults, which works out to be more than 32 million people with a documented allergy to penicillin. And in certain populations, we know that that prevalence is even higher, specifically those who are frequently sick, who are older, or who have had more interactions with the healthcare system. So while it's 10% in like a general pediatric or even adult primary care waiting room, that number is as high as 15% among patients who are hospitalized and is up to 24% of individuals in like a rehab care setting. And that works out to be a huge percentage of the population who can't be treated with that preferred narrow spectrum first line antibiotic for most common bacterial infections. But we also know that not everyone with a documented allergy is truly allergic. In fact, most are not. So this chart here shows the results of a meta-analysis, right? So a study of other studies that looked at 24 different studies in which patients with a penicillin allergy label were actually tested to see who was allergic. Across the studies, more than 1,000 patients with a documented penicillin allergy were tested, and the proportion of people with a negative penicillin skin test ranged between 79 and 100%. So on average, 95% of patients with a labeled penicillin allergy who were then tested were not actually allergic to penicillin. This large discrepancy might make a little more sense now, right? Because the difference between the documented allergy and the actual allergy is often due to simply an original misclassification of the symptoms as an allergic reaction when these were in fact not symptoms of allergy. The other explanation is that even a correctly documented penicillin allergy will typically resolve with time. Now, I don't have the numbers at a population level to know the specific percentage, but many allergies are self-reported. So they show up in a chart and are carried into adulthood. So by the time the adult with a drug allergy label is questioned about the allergy, they often have no memory of the original reaction history from when they were a kid. Even in my own practice, where I exclusively see pediatric patients, you let a few months go by and the details of which symptoms occurred and when and what was used to treat it get real fuzzy real fast. Other times, the allergy was listed on the medical record simply because of a family member's reaction history, right? Or a family member with a drug allergy that gave pause for treatment or concern, whether that be for the parent or the provider. But as we talked about, another explanation is that the symptoms which occurred were simply not actually allergic in nature. This is especially common in pediatrics, where otherwise benign symptoms like a rash or a sore throat or a stomach ache, which were actually caused by the underlying infection, are incorrectly attributed to the antibiotic. So these are going to be the type A known side effect reactions labeled as allergies. And as we discussed, it's also possible that it was correctly identified at the time and it has simply resolved. So we know that about 50% of people with a true penicillin allergy will see that allergy resolve after 5 years. And that's a number that increases to 80% after 10 years of avoidance. So why is this a problem? Well, unverified allergies, I think of the consequences of this in 3 separate categories, right? And I think of it in general in terms of the consequences for population health, the cost of care, and the potential for personal harm. Now, at a population level, the latest estimates I've seen on this suggest that 270 million antibiotic prescriptions are written each year in the US alone. And about half of all hospitalized patients will receive antibiotics. But having a penicillin allergy label forces clinicians to substitute that preferred first-line antibiotic option with a broader spectrum alternative, which directly promotes the development and spread of some of these antibiotic-resistant bacteria, which in turn affect all of us. From a cost of care standpoint, patients with a penicillin allergy both face total higher costs for care and higher personal out-of-pocket costs associated with prescriptions. So there's good data to suggest that hospital stays are actually longer and more expensive for patients with penicillin allergy, and that prescriptions cost 30 to 40% more for patients who have to avoid penicillin. There's even some studies suggesting that once you include the cost associated with the allergy consult and the testing and the challenge for a drug allergy, you still save money by evaluating and testing compared to simply avoiding penicillin going forward. And then, of course, there's the risks for personal harm because not using targeted first line therapies are associated with several other health risks, right? Not only does this leave you with fewer effective antibiotic choices, but there's typically more side effects associated with the alternative antibiotics. C. diff is a common gut infection that occurs when a broad spectrum antibiotic kills off the good bacteria in the gut. C. diff infections can be both life-threatening in themselves and contribute to long-term chronic health issues. Broad-spectrum antibiotics also increase the risk for personally contracting other multi-drug resistant infections like MRSA or VRE. You're at increased risk for surgical site infections and at risk for treatment failure. So in light of all of this, it is understandable that there are lots of interested groups in developing point of care risk assessment tools to determine which patients actually require an allergy referral and which do not. The PenFast tool is a real-time at the elbow support tool for clinicians to help do quick risk stratification of a penicillin allergy. And the factors here include and the factors are here and each correspond to various points. The higher the total score, the greater the risk of having a penicillin allergy. But the factors themselves include the timing of the symptoms, the severity of the symptoms, whether or not treatment was required. And each factor is then assigned that point value. There are various risk stratification models out there that accomplish something similar. The caveat here, right, is that PenFast is verified in an adult population, but not for pediatrics. So there are other scoring tools as well. But the common feature throughout most of them are going to be whether or not symptoms of anaphylaxis were present, and then how long it has been since the reaction occurred. PenFast is one tool. There are additionally, understandably, practice parameters that help direct us when making these decisions about who is actually at risk for a reaction or not. Every few years, the American Academy of Allergy, Asthma, and Immunology and the American College of Asthma, Allergy, and Immunology provide these evidence-based guidelines for managing drug allergies. And the most recent update to these guidelines provided the first major professional framework supporting a simplified, risk stratified approach for removing inappropriate penicillin allergy labels. The document itself is massive, but I've called out here 5 of the specific recommendations which are relevant. So in 2022, the expert groups recommended proactive efforts to delabel patients with a reported penicillin allergy when appropriate. They recommended against testing patients with a history that's not consistent with penicillin allergy. So symptoms limited to diarrhea, headache, or that family history of penicillin allergy. Recommended against penicillin testing prior to a direct challenge in pediatric patients with a history of a mild skin-limited reaction. Suggested direct challenges be considered in adults with a history of a distant and generally benign skin-limited reaction, and then suggested aggressive penicillin skin testing for patients with a history even of anaphylaxis or for a recent suspected IgE-mediated reaction. So these recommendations give us guidance on who needs to see an allergist, who needs a drug allergy challenge, and who may need testing prior to that challenge. But I've thrown around some terminology before we move forward into this actual what does the delabeling process involve. I think it's going to be helpful to step back and clarify terminology. But I also want to check, and I'm going to check back to the chat real quick to see before we move on if there's anything else that I can speak to. Not yet. Thank you guys for listening. Great. don't hesitate to add questions. We're going to move on. Okay, so what does the delabeling process actually look like? Here we go. So evaluation of drug allergies typically begins with a conversation with a healthcare provider. Often an allergist, but this could also be a primary care provider or a hospitalist who's managing an inpatient admission. In certain circumstances, this could even look like a review of past medical records where the reaction history was really well documented. So if you are a person with a documented penicillin allergy or the parent of one, the following are examples of questions that you're likely to be asked during that first step of the drug allergy evaluation. Providers are want to know, when did the reaction occur? What was the reason for the antibiotic use in the first place? What symptoms occurred and how long they lasted? When those symptoms began in relation to the inciting dose of the medication. So is this something that appeared within minutes of actually taking the medication or hours or days later? They'll probably want to know whether or not there has been any prior exposure to the medication, whether you were taking any other medications at the time the reaction occurred, and what treatment the patient received to address the symptoms that were present. On the left is an example of a toolkit that's available through the American Medical Association to guide clinicians in doing this work. So if you are listening instead as a provider, a clinician, but not in a specific allergy practice, there are some really great resources available here for you to do this initial work of evaluating patients for their risk of drug allergy. The point of the evaluation is to risk stratify patients, right? We want to identify the extremes. We want to identify first the patients who really have no risk for being penicillin allergic, and we want to identify those at high risk for a severe reaction. And then to make sense of the sort of muddy middle, right? So examples of patients who are not at risk of a penicillin allergy are those who have never taken the medication and simply have a family member with a documented allergy. Those who were, let's say, labeled with amoxicillin allergy in childhood, but tolerated a course of Augmentin last year that was prescribed from urgent care. Or patients whose symptoms were consistent with those type A known side effect symptoms only. Low-risk patients are those with mild skin-limited reactions that occurred a very long time ago, right? These are the candidates who may be a good candidate for a direct oral challenge to the medication. Moderate risk patients are those who may benefit from a combination of testing and challenge. There is a general rule of like the 1-to-1-to-1 principle, which is if the symptoms appeared within 1 hour of the first dose of the medication and involved one or more symptoms, these may be candidates who we want to reserve greater suspicion for true allergy. And then there are those who are at high risk for having an adverse reaction to the medication. And these include not actually the patients with a history of anaphylaxis, but rather those with some of the more delayed severe type reaction. Those who had had serum sickness-like reactions, something like Stevens-Johnson syndrome, DRESS, or some of the other more severe delayed type symptoms where future use of the antibiotic would simply be contraindicated. Once patients are risk stratified, then the decision is, where do we go next? And there are a few options. For those patients at moderate risk of reaction, we typically will do some form of testing first. Skin testing is typically done prior to an oral challenge, and this is typically done in an allergy clinic, although there are kits available for use in other healthcare settings as well. Skin testing is typically a two-step process. And so let me say a little bit about what's involved, and then we can talk about some of the numbers below, which is like, yeah, but how accurate is any of this? So skin testing starts with something called skin prick testing. And for skin prick testing, a plastic applicator applies small amounts of one or more penicillin reagents to the surface of the skin. Typically, testing is done, as is shown in the picture here, on like the volar surface of the arm or sometimes right in the middle of the back. And a positive test would be if the patient develops a hive to where the medication is in direct contact with the skin. A negative test would be no skin reaction and would then be reason to proceed to the second step of testing, which is intradermal testing. For anyone who's ever had like a TB test done in their forearm, this is a similar intradermal, so just below the surface of the skin injection, typically with increasing concentrations of the medication, to see again whether or not it elicits a positive reaction in the skin. The picture here on the left is an example of what a positive reaction may look like. If you've ever been bit by a mosquito or experienced hives, that is what we are looking for on the skin testing to suggest a reaction to the medication. Typically, histamine and saline are placed to be positive and negative controls as well. And the accuracy of skin testing is actually fairly good. So the numbers here are, again, from a meta-analysis of lots of different studies evaluating the effectiveness of skin testing. So for this, over 30,000 patients were reviewed for the accuracy of testing. This is across, I think, like over 100 different studies that looked at this. In terms of the language here, so specificity refers to the test's ability to correctly identify patients with the allergy, whereas sensitivity is the test's ability to correctly identify patients without the allergy. And then a negative predictive value is the probability that a person who received a negative test result truly does not have an allergy. So for penicillin, allergy testing in general, skin testing is very reliable at confirming the allergy, but has relatively poor sensitivity, right? So a negative test doesn't definitively rule it out. However, when the prevalence of a particular condition is small, as is the case for an IgE-mediated penicillin allergy, even a test with like a modest sensitivity can actually have an excellent negative predictive value, which is the case here with penicillin. So skin testing is a really great place to start for patients at moderate risk of a reaction. And yet, many patients may not need that testing to begin with. So the gold standard for confirming a clearing an IgE-mediated penicillin allergy is an oral challenge. Now, there's different terms for this. Sometimes it's referred to as a direct challenge, which is simply an oral challenge performed without first doing the skin testing. And then challenges themselves are either done as a one-step or a two-step challenge. In a one-step challenge, you're simply given a dose of the medication and observed for a period of time afterward. Whereas in a two-step challenge, that dose is typically split into a 1/10 dose and 90% or 9/10 dose, spaced out by a period of observation in between the two. After the dose of the medication is given, and typically, again, this is in an allergy clinic, although increasingly more and more pharmacies, inpatient centers, and even outpatient primary care groups are doing oral challenges to the medication. A patient's going to be periodically monitored and examined for a minimum of an hour afterward. The most common symptoms to occur during an oral challenge are going to be subjective symptoms, such as itching, like without a rash, nausea, stomach upset without vomiting or diarrhea. And these symptoms are usually side effects or symptoms of anxiety arising from the challenge. If no objective symptoms occur, the patient will then either proceed to the second step of the challenge or be cleared of the allergy. Mild skin symptoms are the second most common symptom to occur and are themselves typically mild and self-resolving. It is possible, although it's rare, that a more severe allergic reaction might occur during a challenge to the medication. Systemic symptoms of an allergic reaction, such as anaphylaxis, will include diffuse hives, facial swelling, shortness of breath, vomiting, lightheadedness, or a drop in blood pressure. And should a more severe symptom such as these occur during a challenge, patients will likely be treated with antihistamines and epinephrine in clinic. This would also likely prolong the period of observation after the challenge. But patients who complete the oral challenge without these symptoms can be cleared of the allergy label, and the medication can be used again if clinically indicated in the future. One important note that's worth looping back to is that testing for drug allergies is limited to IgE-mediated reactions, right? The immediate hypersensitivity reactions that are mediated by those allergic antibodies. And while testing and challenge can confirm or rule out an IgE-mediated allergy, this type of testing cannot predict if a delayed reaction would occur following like a full therapeutic course of the medication. But if there's been no prior reaction history to that, then your risk for that type of reaction is going to be the same as mine or anyone else's, which with any future use of the medication, which is to say it's fairly low. This last thing I want to look at, I think validates what the updated 2022 practice parameters suggested, which is that although the combination of skin testing and challenge may theoretically sound more reassuring, comparisons of direct head-to-head trials between drug challenges and penicillin skin testing found that a direct challenge to the medication in patients at low risk for allergy actually does a better job of clearing patients of allergy than the penicillin skin testing does alone. So in this study, there were, which was published back in 2019, so before the 2022 practice parameter updates came out, this found that for those low risk patients, the drug challenge was better than the skin test at clearing the drug allergy. Now, this study is great because it's a randomized controlled trial, which we love because it's a nice controlled experiment. The qualification, the like thing that made you considered low risk is that you were older than 5 years of age at the time of the test or challenge, that the original reaction was limited to skin symptoms, and it had occurred more than 1 year ago. And so what they did in this study is they found a population of patients that met that criteria. And it was the N for this, the number of patients enrolled was 159, almost 160. And they split them into two equal groups. One group was directly sent to a drug challenge or an oral amoxicillin challenge, while the other group received the penicillin skin testing first. And so while the risk factors were the same, more patients were cleared of the drug allergy through a negative drug challenge than those who had skin testing, suggesting that although this study is small and follow-up is obviously needed, it reinforces the idea that for patients with a low risk of allergy, direct oral challenges may actually be the more expeditious, more cost-effective, less expensive way of getting to the direct answer of whether or not this is still a relevant allergen. There have been a lot of studies since this. This is a huge topic of research. There's a slide deck next looking at even larger studies and more populations. The data points that I typically speak to when I'm counseling patients about this in clinic is that across the studies from the literature, what we know is that on average, about 5% of patients will have some kind of reaction during a drug challenge, but less than 1% of them will have an immediate type reaction during the challenge. So given that penicillin allergy is, let me advance the slide here. Given that up to 95% of people who are labeled with penicillin allergy are not actually allergic, given that penicillin is the optimal treatment for many common infections, and for most people, penicillin is safe and effective, it is so important for individual patients and for the healthcare system as a whole that these drug allergy labels be verified and removed whenever possible. There are some great resources that I used and or plagiarized to get through tonight's presentation. They are here in the reference slide. There are some great patient-facing resources available through the American Academy of Pediatrics, as well as the Quad AI, the allergy and immunology group. Um, I left, I hope, just enough time to sort of speak to questions that you guys may specifically have about anything that has been discussed tonight. So let me stop this share and open the chat so I can see faces and try to
I
answer
think
any
you have a
questions you
new
guys may
one,
have.
Ashley. I think you have
Wonderful.
a new question here from
Wonderful.
Rachel. Are direct challenges typically performed for other types of antibiotics, for example, cefadroxil, in addition to penicillin and amoxicillin? Thank you, Rachel.
They, yeah, thank you so much. Yeah, they are. So there are, and different allergy groups will have their own testing protocols for different medications. They're largely informed by some of the same practice parameters and the 2022 updated guidelines. But yes, direct challenges for various medications beyond penicillin and amoxicillin are widely used, and the validity and accuracy of skin testing is going to vary dramatically based on the different medication.
Excellent.
I
We have
just
time.
I
Any
just
other
want to,
questions?
hi Jen, how are you?
Hi, Giovanni. Giovanni is a board member, and I guess you have a question.
I don't have a question. Ashley, it's so good. Jen, Ashley and I go way
Way
back,
back.
way back. Ashley, this was an excellent presentation.
Oh, thank you.
She is an even better child life specialist than she is a nurse practitioner. I've worked with Ashley at Boston Medical Center. She used to be our child life specialist. So she had not even started school when we started working together. And now she's done with school and she's working. Oh my God. Ashley, I am so happy to see you. This was
Oh,
such a great presentation. I am
thank
so
you.
proud of you. Oh my God. Like, my heart is so warm. I saw your name and I'm like, I am coming. I'm coming. I'm coming. I'm coming. I'm coming. And I'm so happy I made it. This is
I
beautiful.
I love that. It is so wonderful to see friendly and familiar faces here. And yes, we do go way back.
Well,
Thank
I
you.
love that, Giovanni. Thank you for sharing that. And
Of
there's no
course.
doubt this was an incredibly thoughtful, thorough presentation on a topic that I certainly wanted to learn more about. Unbelievable, Ashley. And I think we have a new question, which is great,
Yes.
from Nurse Pam for children, especially very young. What is the suggestion for when trial PCN again after having a rash during a previous testing, or is it more for adults? I think I read that correctly.
Yeah, great question, Pam. Yeah, so the 2022 practice parameters do recommend waiting a minimum of 12 months from a suspected reaction before doing any direct challenge. Some of the studies have looked at children only ages 5 and older, although in our practice, we will test a 2-year old as long as it has been a year from the reaction. One really encouraging and exciting move is even to consider whether or not patients with a history of a benign, so typically non-urticarial rash, need that referral in the first place. We're gathering data right now and looking at indications for actually treating through some of those morbilliform rashes, especially in kids who are being treated for ear infections or strep throat infections, where that rash is quite likely to be related to the infection rather than the antibiotic. So one hopeful recommendation we can begin offering soon once we have a chance to look at data is actually when it may actually be okay to simply treat through those rashes and not discontinue the amoxicillin typically in the first place in those young kiddos.
Excellent. And I think there's a follow-up from Nurse Pam. So should trials for the very young be definitely done through the allergist office?
Yeah. I think that depends on the resources in the alternative setting, right? So if the alternative setting is a primary care group with staff trained in anaphylaxis management and recognition, with access to epinephrine and resources to support a severe reaction should one occur, there is no reason why it has to be in an allergy practice. I think practically speaking, most of the time those challenges are being referred to allergy, where that's a completely appropriate referral to do. I think one of the real challenges facing the system is that, and this is really the work that got me into this, is that most places don't have access to pediatric allergists. Um, Even in places where access is widely available, like it is here in Boston, wait times are prohibitive in many
Crazy.
cases. And so we are really doing here at Children's, what we have actually done is we've carved out a fast track clinic for patients specifically with amoxicillin allergy, where they don't have other atopic concerns. The reason for referral is specific to drug allergy. And we now are doing a once a month virtual clinic for those families to take that history and do that risk stratification, trying to increase access for young patients with drug allergy concern. But right, this is a real challenge. We are here at Children's also partnering with a lot of the PPOC practices to support their own internal systems and protocols for identifying, labeling, and determining which patients may actually be safe for an in-clinic challenge versus those who need referral. So there's a lot of exciting work on this front, lots more to do. So that's a long answer to say, not always, hopefully not forever, but for right now, often yes.
Excellent answer. Sometimes long answers are the best answers. And kudos to Boston Children's for fast tracking because, as you said, if you live in an area where there isn't, an allergy practice to do these kinds of things, or in Boston, as you said, the waits can be months.
Yeah.
And so to fast track it, kudos to Boston Children's Hospital. We do
Yeah.
have a few minutes if there are any other questions that people might have. I'm not seeing any, but and I want to make sure I didn't miss any. You're getting a lot of thank yous, by the way, Ashley, for what was an excellent presentation. So
Right.
Giovanni, thank you for starting that ball, for sure. I did see something when people were just checking in, and you had asked for folks to just kind of identify themselves and why they're here. And there was something that, if I'm remembering correctly, that someone asked, referenced, is there a overlap between drug allergy and food allergy?
Interesting. Um, as with lots of other allergic type or atopic conditions, there is some degree of overlap in terms of the genetic predisposition for developing dramatic immune responses. So I tend to say I deal with the overactive immune systems, right? The overachieving immune systems, typically rather than the underperforming ones, which are, owned by my respected colleagues in immunology. It Drug allergy in particular does not disproportionately affect patients with other forms of allergy, though. Part of that is we don't have great data. We know our data is poor, right? We know we have a disproportionate report of drug allergy, but actually figuring out which of those patients actually are allergic is limited, but not especially. You are not at greater risk for a penicillin allergy because of eczema, in the same way that you're at greater risk for developing a food or environmental allergy, if that helps answer that question.
I would think it would. I think that's
Right.
fantastic. I thank you so much. I learned so much. And full disclosure, I was diagnosed with a penicillin allergy years ago. And trust me, from the color of my hair, it was more than 5 years ago. So I probably should be retested myself. Thank you,
Right.
Ashley. And I think the message for everybody here is that if you think that you might have, or someone that you care for, Love has been diagnosed with a drug allergy, and it's been a period of time. Might be worth being retested by an allergist for all of the many reasons that Ashley shared with us tonight. I hope you all found this as incredibly helpful as I did. As always, if you have any specific questions beyond this program, please contact your healthcare provider and ask that person to help you out to get some good answers. Thank you again, Ashley, so much for tonight. This is the first